welcome back. For today's video, I am going to be talking all about endocrine disorders, specifically thyroid disease and diabetes, because this is what you will be seeing on your boards exam and primarily what you will see in your practice as well. I will focus on the process of diagnosis, pharmacological treatment, follow-up, and then warning signs that you need to look out for when managing patients with these diseases. At the end of the video, as always, I did include a dump sheet to help supplement your studies. And don't forget to leave me any questions you might have. And also don't forget to subscribe to this channel if it's been helpful for you in your studies. And now on to endocrine disorders. So first up, I'm going to discuss with you thyroid disease, and it's important obviously to know the thyroid markers to look for. So I listed them here for you. You'll see the TSH, T4, and T3. The TSH, or thyroid stimulating hormone, that's going to be the best screening test to screen for both hypo and hyperthyroidism. So depending on the results of the TSH, that's going to further dictate how we are going to follow up with these patients. If the patient's TSH is normal, then no further testing is indicated. However, if the TSH is high, this indicates hypothyroidism, and we can add a free T4 to determine the degree of hypothyroidism. If the TSH is low, then this indicates to us the patient has hyperthyroidism, and we can add the free T4 and T3 to further determine the degree of hyperthyroidism. Exceptions to these rules is going to be the two that follow here. So if a young woman presents with amenorrhea and fatigue and we have concern that she may have pituitary or hypothalamic dysfunction, then initially we'll want to order a TSH and T4. And then also if our patients are having symptoms of thyroid disease but they have a normal TSH, then it's indicated for us to order a free T4 then as well. Also, a couple of things that I wanted to point out on this slide that I didn't mention. One, I did include the normal values for you there for the thyroid markers. Not to worry as far as remembering them. Those will be provided to you on your exam, but just for your reference there. And then also something I didn't include, but important to note, is that a big difference between the T3 and the T4 is that T3 is actually 5 times more active than T4. This is because T3 is not as tightly bound to the plasma proteins, making it more readily available for cellular uptake. Okay, so hypothyroidism is divided into two categories, primary and secondary. Primary hypothyroidism, the pathology is of the thyroid itself, and 95% of thyroid disease or hypothyroidism is primary hypothyroidism. Secondary hypothyroidism is when the pathology is outside of the thyroid. Labs, those are going to be seen with a high thyroid stimulating hormone or high TSH, remember, that indicates a low thyroid, and then a low T4, and those labs there indicate hypothyroidism. Hypothyroidism is up to 8 times more common in women, and symptoms of this include fatigue, weight gain, intolerance to the cold, constipation, menstrual irregularities, bradycardia, so things slow down, or hypothyroidism, things slow down. There may be a goiter present, and this is if either A, it is due to a iodine deficiency, or B, due to Hashimoto's disease, which is a chronic autoimmune thyroiditis. Hashimoto's is actually the most common cause of primary hypothyroidism in areas where iodine deficiency aren't an issue. And then elevated TPO, or thyroid peroxidase, that is in 90% of patients with Hashimoto's, and it's actually the gold standard for diagnosing Hashimoto's disease. And I included for you the normal range there, though obviously you know you don't have to know that for boards. Areas that are going to be at a greater risk for hypothyroidism due to iodine deficiency are going to be areas like Southeast Asia and Africa. So treatment for hypothyroidism is levothyroxine, that is a synthetic thyroxine, or T4. There, I listed the doses for you there. They can come in a range of doses, ranging from 25 mics all the way up to 300 mics a day. For the elderly population and any of those with coronary artery disease, we actually want to start them at a very low dose to avoid any kind of cardiac side effects for them. So a low dose, that is somewhere even between 12.5 to 25 micrograms a day, or up to even 50 micrograms a day, some of the literature listed. And again, that's because we want to reduce the side effects for them. And then we'll increase that at 2 to 4 week intervals up to the dose that we had intended for them. And then education points for the patient is that they should take this medication on an empty stomach. Ideally, it would be 30 to 60 minutes before breakfast. And then when starting on a new thyroid medication, ideally we want to reassess those patients in between 4 and 6 weeks after starting the therapy. And then if the TSH is normal and their symptoms are resolved, then we can go to checking them annually. Also, we can let our patients know that they should expect to see symptom improvement as early as 2 weeks after starting therapy. The most common cause for hyperthyroidism is going to be Graves' disease, and this is actually an autoimmune disease. And labs that will indicate hyperthyroidism include a low TSH and a high T4 and T3. Symptoms of hyperthyroidism include anxiety, tremor, heat intolerance, tachycardia, weight loss, increased perspiration, and increased appetite. On physical exam, we might note that the patient is hyperactive, has lid lag, lid retraction, warm, moist skin, fine hair, hyperreflexia. Generally, there is thyroid enlargement seen with these patients, and it can range anywhere from minimal to severe enlargement. And then those patients that where it is Graves' disease, oftentimes something called exophthalmos will be seen. Exophthalmos, hopefully I said that. Periorbital and conjunctival edema, and there's a picture of it there, just bulging eyeballs. And then patients with Graves' disease are actually at a greater risk for both osteoporosis and atrial fibrillation. I very briefly mentioned here the treatment options for hyperthyroidism, but these patients actually need to be referred and managed by endocrinology. There's 2 thyroid emergencies that you want to know about. One is when it's severely high, and one is when it's severely low. So the thyroid storm is in regards to severe hyperthyroidism. Left untreated, this has an extremely high fatality rate of 90%. And symptoms for thyroid storm include tachycardia, fever as high as 106 degrees, altered mentation, for example, agitation, delirium, and for obvious reasons, these patients are going to be managed in the ER. And then the myxedema coma is for severe hypothyroidism, and I remembered it by remembering my X's and O's. So myxedema, hypo, X's and O's, that help me keep them separate from one another. And this also has a pretty high fatality rate. 30 to 50% of patients will die if this is left untreated. And symptoms include now opposite, so decreased mental status, hypothermia, bradycardia, hypotension, hypoglycemia, hypoventilation. Everything really slows down. Obviously, again, these patients have to be managed in the ER. And important to note is that myxedema coma, this can occur with abrupt cessation of their thyroid medication therapy. So that's really important for educating our patients that they cannot just abruptly quit their thyroid meds. It comes with some serious risks. And then also I included here symptoms of thyroid cancer, the big one being a solitary thyroid nodule. And the definitive diagnosis for this is actually going to be made with a biopsy. So a super brief refresher here in regards to type 1 and type 2 diabetes. Type 1, this is where the patients are insulin deficient. Pancreas does not produce enough or any insulin. Generally, this presents early in life, though it can appear in all ages. And these patients require insulin therapy. Type 2 is where patients are insulin resistant. So they have insulin, but their body doesn't use it properly. Over 90% of patients with diabetes actually have type 2 diabetes, and that explains why this is what you really want to focus on when studying for your boards exam is going to be type 2 diabetes. These are the questions that you're going to see. It's going to be managing these patients here. So who do we screen for diabetes? There's a population that we are going to screen every 1 year, and then there is a population that we will screen every 3 years. So the group of people that we're going to screen every 1 year are those patients that have a BMI of 25 or greater, plus one or more risk factors for diabetes. And some other risk factors for diabetes aside from obesity include things like a family history of diabetes, specific ethnicities including Asian, Hispanic, and African American ethnicities, and then those patients with a sedentary lifestyle are also going to be at an increased risk for diabetes. And then the individuals that we're going to be screening every 3 years, these are our patients 45 years and older. Regardless of anything else, we are screening these patients every 3 years for diabetes. So I listed for you here the pre-diabetes and type 2 diabetes numbers. It's really easy to remember when you just remember pre-diabetes, and then everything above those ranges are going to be your type 2 diabetics. So for pre-diabetes, A1C is going to be 5.7 to 6.4%. Anything above that 6.4% indicates type 2 diabetes. So a fasting plasma glucose of 100 to 125 is your pre-diabetes. Anything above that 125 is going to be indicating type 2 diabetes. And then for the oral glucose tolerance test, the pre-diabetes results are going to be between 140 and 199. Anything above that 199 indicates type 2 diabetes. And then one extra one here is a random plasma glucose, so random blood sugar greater than 200, and at least one of the three Ps, so that's polyuria, polydipsia, or polyphagia, then that also indicates type 2 diabetes. And a diagnosis of type 2 diabetes should be made with two elevated values. On the side here, I included what our goal A1C for our diabetes patients. And you don't have to remember these numbers verbatim as well, but I listed them here for you for reference, and it's kind of important to know like a general idea then. For example, for the elderly population with comorbidities, we're less stringent on their A1C. So we want their A1C between 8 and 8.5%, whereas the pregnant patient, we're much more strict on the A1C. We want to see that below 6%. But for most adults, an A1C below 7% is going to be ideal. All right, so this slide here is a quick little case study example. So a 50-year-old female with a family history of diabetes reports weight gain. Her random plasma glucose is 211. What is the plan? So we will first assess for any of the three Ps, because remember when we were talking about diagnosing type 2 diabetes, if they have a random plasma glucose above that 200 range, plus one of those three Ps, then we can go ahead and diagnose them with type 2 diabetes. So if we have a patient presenting with a random plasma glucose above that 200, first, before we diagnose them with type 2, we need to first assess if they have any of those three Ps. If they do, if they have polyphagia, polyuria, polydipsia, any of them, bam, slap type 2 diabetes on them. Treatment for that is going to be metformin if it is not contraindicated. And in the next slide, we'll go into metformin more thoroughly, but just for reference, this is where you would start with that patient generally. So same patient, 50-year-old female, family history of diabetes, reports weight gain. Her A1C is 7.4%, and her fasting plasma glucose is 160. What is the plan? Well, here we have two separate elevated readings. Her A1C and her fasting plasma glucose are both elevated, so we can give her a diagnosis of type 2 diabetes and treat with metformin if it is not contraindicated. So next up, 50-year-old female, history of diabetes, reports weight gain. Her fasting plasma glucose is 118 and her A1C is 6.2%. What is the plan? So if we think back on those numbers and our pre-diabetes numbers, this patient actually has pre-diabetes or impaired fasting glucose. What is our plan for these patients? Well, now that they have risk factors, we're screening this patient every 1 year. or of course if any new symptoms of diabetes were to develop. But otherwise, this is the patient that we're screening annually because of their risk factors. Last one, 50-year-old female, history of diabetes, reports weight gain. Her A1C is 11%. So this is also known as glucose toxicity. What is your plan for a patient with this high of an A1C? Anything above double digits, all the literature says that you need to be putting this patient on insulin. And then if glucose down the road is better controlled and better managed, then they might be able to transition to oral medication. But initially we have to, break out the big guns and use insulin for these patients. And obviously they're going home with the diagnosis of type 2 diabetes. So metformin is going to be our initial therapy for all of our type 2 diabetic patients. And metformin is a really great drug. If we can have our diabetic patients on this and keep them on this, then that is going to be best for our patients. There's a lot of benefits to this medication, including no changes in weight or even possible weight loss with this medication. Also, it does not cause hypoglycemia, so that's huge for reducing that risk factor. Also, metformin has been linked to reducing cardiovascular events and even possibly reducing cancer. It does have some important contraindications to make note of. It is contraindicated in patients that have risk of lactic acidosis, and this includes renal insufficiency. Therefore, anyone that has a GFR less than 30 are unable to take metformin. Also, patients with severe liver dysfunction, I put sever, but severe liver dysfunction, active alcohol abuse, decreased tissue perfusion, and or hemodynamic instability. All of these patients, metformin is going to be contraindicated. GI side effects are going to be the most common side effect that is seen with patients taking metformin, and so it's really important for you to know what it is that you're supposed to do as a provider if your patient starts experiencing this side effect. So you'll have the patient stop the metformin until the diarrhea resolves, and then you'll restart them on metformin because it's so important that we try and keep our patients on this medication. But we're going to restart at a lower dosage, and we will titrate even slower depending on the patient's needs. Our goal is to ultimately end on that desired dose, but we can go as slow as needed to avoid those nasty side effects and to ultimately keep our patient on metformin. Other side effects that are common or that you might see with metformin is a reduction in vitamin B12 absorption, and that's seen in about 30% of patients taking metformin, and this can actually sometimes cause anemia, so just something to look out for. For the majority of patients, if within 3 months of starting metformin and implementing lifestyle modifications, eating more healthy, getting exercise, but they're still not reaching that A1C goal, well, then it's going to be recommended that we add on a second agent, possibly another oral medication or an injection. And so the next slide here will go over, the next couple slides here will go over some further diabetic medications. So this slide here is really great because it kind of consolidates all of those key points that you really need to know with these diabetic medications. And there's a lot of really important stuff here for your boards and for practice. And I just wanted to point it out really fast that actually my second episode of this series, I dedicated a whole video all about diabetic medications, and this information was taken directly from that. I elaborate a little bit more on that video in regards to these medications because it's solely dedicated to that. So if you're finding yourself struggling with diabetic medications, then I urge you to go over there and also watch that after this. But so anyways, let's jump into this. So I listed for you here the additional type 2 diabetic medications. So you have your SGL2 inhibitors, and those all end in flows. And then your DPP4 inhibitors, and those all end in leptin. Your thiazolidinediones, which end in zone. Your GLP-1 receptor and agonists, which end in tide. Your sulfonylureas, which end in ide, and then insulin. And so I'm going to just encourage you to read over this graph because it's kind of funky for me to sit here and read it for you, but it's important. Really important, though, is that you understand the advantages and disadvantages of these drugs. And I'll read over just some ones that you really want to focus on and make sure that you know for boards. So your SGL2 inhibitors and your GLP-1s, it's important that you know that these are linked to reducing cardiac events. For your thiazolidine and your DPP4 inhibitors, you need to know that you should avoid these drugs with your patients with heart failure. And then sulfonylurea, it's a cheap option, but there is a big risk for hypoglycemia. So just some important ones, but you can read over these here. And then also in quotations underneath the names of the drug classes, I included my little tricks for how I remembered the names of the drugs and what class they belong to. And again, in my second video that I was just talking about, I kind of go into that a little bit more of my tricks and how I remembered the drugs. But in a nutshell, all of it is here for you. So if if your patient's A1C is greater than 9%, and this is from Up to Date, then it is indicated that you use insulin or a GLP-1, which is also an injection, to manage these patients. And then again, like I had mentioned earlier, once you get their glucose more under control, you might be able to switch them to just oral drugs. But initially, with that high of an A1C, it's important that we bring that glucose down, and it's going to need to be done with something like an insulin or a GLP-1. So this slide here just shows you the different types of insulin, their names, their onset duration. Do not stress yourself out in studying this. It's not important that you remember all these numbers, and I more put this here for your reference. A couple of things that I suppose it is good to have a general idea of, though, is obviously things like the immediate insulins, those Novolog, the Humalog, they act very fast. So it's just a general idea, and this is kind of all intuitive. I mean, you know this already. And then long-acting, for example, Lantus or Levemir, those last for 24 hours, and their onset takes about an hour. So generally know a little bit, but do not stress yourself out in remembering these. You just don't need to. So the management of our patients with diabetes requires a lot of tests and follow-ups. So I listed them all for you here. All on the left-hand side are all of the tests, and then on the right-hand side are the frequency in which those tests are to be carried out or when they are to be initiated. So for example, the A1C, of course, it's going to be done at diagnosis, but then every 3 months until we have reached our A1C goal, and then they'll actually have their A1C checked 2 times a year. Other ones are listed, including albumin and creatinine ratio, your GFR, thyroid stimulating hormone. An important one is the dilated eye exam. So that is for our type 2 diabetes. We're actually going to do this exam at diagnosis, and that's because we don't know how long this disease has been going on, and if there is already some retinopathy or eye disease present. So we'll do it at diagnosis, and then if there's no complications, then it's okay to do it biannually. However, if there is retinopathy present, then we need to do a dilated eye exam annually. For our patients with type 1 diabetes, we can do this dilated eye exam within 5 years after diagnosis. And then the same, if they have no complications, biannually is appropriate, or if retinopathy is present, then we need to do it annually. And then foot exam, obviously we know that's really important for our diabetic patients. This should be every 3 months or every visit if the patient has neuropathy. All right, so the last slide here is just different clinical pearls, warning signs, and emergencies related to diabetes, just some important stuff that you should know. So first point being that if our patient with diabetes is sick, per the CDC, we want to educate that they continue to take their insulin or any of their other diabetic medications because, one, we know that infection can really affect a patient's blood sugar and make it really hard to manage, and we want to avoid them becoming very hyperglycemic due to their infections. We want them to continue to take their medications, but to, of course, be monitoring their blood sugar even more closely. It is recommended that they check it every 4 hours and then record them. So for diabetic ketoacidosis, this is likely if our patient is experiencing a serum glucose of greater than 300 and they have ketones in their urine. And this is going to be managed in the hospital. So we'll actually go ahead and refer them to the ER. Diabetic retinopathy, important just to know that microaneurysms, this is what we're looking for with diabetic retinopathy, and just important key term for your exam. And then the Smogy phenomenon, this is rebound hyperglycemia, and this actually results in a high blood sugar in the morning, but it's related or due to episode of hypoglycemia at night. And important to know is that this could actually be caused from either taking too much insulin in the evening, or if the patient decides to skip a meal in the evening, then they might have that Smogy phenomenon. So just something important to look for and to screen if our patient is coming in with these high blood sugars in the morning. We can check and see if they're taking too much at night or if they're skipping meals in the evening, and this is just easy resolution for the problem. All right, so this means that I have reached the end of my discussion. As always, here is your dump sheet to help supplement your studying. It's completely dedicated to the endocrine disorders, including thyroid disease and diabetes, and it covers all of those points that you have to know for your board's exam and entry into practice. As always, please leave me any comments or questions that you have down below. If you have a topic that you'd like to hear me discuss, then go ahead and leave that down there as well. Also, don't forget to subscribe to this channel if it's helped you in your studies, and also I welcome you to share it with anyone that you think might benefit from it as well. I really do appreciate your support. All right, guys, as always, take care, and I'll talk to you soon.